Welcome to this webinar on treatment of skull deformities in children. In this webinar, we will discuss craniosynostosis. We have no financial disclosures. My name is Phuong Nguyen. I am a craniofacial and pediatric plastic surgeon. I serve as the Director of Craniofacial Surgery here at UT Health and Children's Memorial Hermann Hospital. I'm an Assistant Professor of Surgery at UT Health. I am also fellowship trained in both pediatric and craniofacial surgery. My areas of interest and expertise are in craniofacial surgery, cleft lip and palate, facial reanimation, orthodontic surgery or jaw surgery, as well as head and neck reconstruction. I'm also quite interested in clinical and basic science research, particularly in neural tissue engineering.
Hi, I'm Manish Shah. I'm one of the UT Health pediatric neurosurgeons. I am the Director of Pediatric Spasticity and Epilepsy Surgery here at McGovern Med School and Children's Memorial Hermann Hospital. I work closely with Dr. Nguyen. One of my major interests is craniosynostosis surgery, and we're very excited to have you all here to talk today.
As discussed, our main hospital and area of work is Children's Memorial Hermann Hospital. The Texas Cleft Craniofacial team is the longest standing cleft and craniofacial team in Houston, Texas. These are our team members. My partner in plastic surgery is Dr. Matthew Greaves.
My two partners in pediatric neurosurgery are Drs. David Sandberg and Stephen Fletcher.
In today's webinar, we'll discuss the classification of head shapes and abnormalities, a brief overview of craniofacial anatomy, and discuss what is craniosynostosis and why does it need surgery? What are the surgical interventions? What are the pluses and minuses of each? And we'll have an opportunity for questions. Head shapes really come in all shapes and sizes. And the biggest difference is to understand, is there actually something wrong underlying that skull shape? In this talk, we'll discuss craniosynostosis, which is a pathologic fusion of some of the skull bones. The cranium, or skull, is made of 8 cranial bones, and they're connected by sutures or joints. These allow movement of the cranial bones, and this is what allows babies to come through the birth canal. It is also a site of major growth. Normally, these sutures fuse much later in life, between 22 and 26 years of age, with the exception of the Metopic suture, which is the one right in front. Cranial growth in children normally occurs until 6 or 7 years old. What happens with craniosynostosis? It's predicated on a concept called Virchow's law. Normally, the skull grows as the brain grows, and this is done perpendicular to these open cranial sutures. However, when one of these sutures is fused prematurely, we now no longer have perpendicular growth, but parallel growth. And what this does is causes abnormal head shapes and potential restriction for brain growth, as seen in this example here, which is a sagittal craniosynostosis. In general, craniosynostosis can be seen in 1 in approximately 2,500 births. It can be classified as either a syndromic versus non-syndromic. Non-syndromic cases are much more common than syndromic cases. Syndromic cases may also have manifestations of the hands and feet, as well as other cognitive issues. So what are these head shapes? Well, it really depends upon what suture is affected. We discuss the major cranial sutures. Here we see a variety of head shapes. The unicoronal on the bottom left demonstrates a flattened head on one side, and this is an asymmetric head shape. Bicoronal synostosis shows a much more flattened head shape. A metopic craniosynostosis shows a more of a triangle type head shape. A sagittal synostosis shows a more elongated head shape, and the lambdoid synostosis shows more of a trapezoid type head shape. We will go further in depth in each of these diagnoses. How do we measure a shape of a head? The easiest way is to use something called a cephalic index, also known as a cranial index. This is a quick and dirty way of identifying any types of abnormalities. This is measured by the width or the breadth of the head from ear to ear, divided by the length of the head from the front to the back. This gives us an idea and a ratio of what type of head shape we're discussing. It can be long and narrow, such as a dolichocephalic, also known as scaphocephalic, where the cranial index is less than 75, or flat and tall, like a brachycephalic, where the cranial index is greater than 83. A normal cranial index is between 75 and 83. Now let's go through each of these diagnoses. Metopic craniosynostosis has now become the second most common craniosynostosis. Again, this is the only suture that fuses in childhood. Normally and physiologically, this closes at 8 to 9 months of age. However, when it closes before it should, one sees a triangle-shaped head. Also, the eyes are much more narrow. That's called hypotelorism. Oftentimes, one can be mistaken when you see a ridge in the front of the head as opposed to an actual triangle shape. This is called a metopic ridge versus a metopic craniosynostosis. It's important to make this distinction because one requires intervention or surgery and one is normal. To see this, one option is to identify this omega sign on a CT scan. Ask your surgeon about this should you have this diagnosis. The most common craniosynostosis is a sagittal craniosynostosis. This is the early fusion of the midline suture, which causes a boat-shaped head, also known as scaphocephaly. There's bulging of the forehead and the back of the head, as well as narrowing of the sides. Unicoronal craniosynostosis, which vies with metopic synostosis as the second most common, affects one side, and this demonstrates a asymmetry where the eye and orbit are actually pulled up and out, and a flattened forehead is also seen. Oftentimes, you can also see the baby tilt the head to the level of the gaze. Less commonly is bicoronal synostosis. This is manifested as a brachycephaly or short and flat head. Because more than one suture is affected, this may have a higher chance of elevated brain pressure. Lastly, we have lambdoid craniosynostosis. This is the most rare of the major sutures. This affects approximately 1 in 100,000 patients. This is manifested as a trapezoid-shaped head and sometimes may be very difficult to differentiate between the more normal and benign deformational or positional plagiocephaly. How do we make that distinction? Well, the easiest way is to look from the top down, or the vertex view. If you see more of a parallelogram shape, this is more consistent with a positional plagiocephaly. This is opposed to a trapezoid shape, which is more consistent with lambdoid or unicoronal craniosynostosis. So now we know what the shapes look like. Why do we treat craniosynostosis? Well, there are several aims. One is to correct the head shape and the symmetry. Two is to correct the elevations and the pressure on the brain. This can be manifested as either headaches, learning or developmental delay, vision issues, and even blindness. And lastly, there is more and more evidence that there may be associated neurocognitive delay if craniosynostosis is not attended to. There have been some recent reports from Yale and the University of Pittsburgh that have demonstrated that patients who receive surgery for craniosynostosis at less than 6 months actually have improved long-term neurological outcomes. There is also evidence based on information from the University of Kansas that demonstrates that craniosynostosis repair greater than 12 months still does have improvement in neurocognitive outcomes. The bottom line is surgery does help these patients. The easiest way to determine if there is increased intracranial pressure that is non-invasive is a concept called papilledema. This is performed by an ophthalmologist or an eye doctor. The eye doctor looks within the retina and assesses for any evidence that there is flattening of this optic disc. This can be secondary to increased pressure inside the brain. There is more concern that we are not detecting all the patients who do actually have increased intracranial pressure. Perhaps we are underestimating this number, because really the only true way to assess for increased intracranial pressure is a more invasive technique of direct monitoring performed by a neurosurgeon. One small note about Syndromic Craniosynostosis. This is a subcategory that has a genetic basis. There are several syndromes that are associated with this, which you can see in the table below, such as Abert, Cruzon, Pfeiffer, Carpenter, Muenke, and Saythree-Choatsin. These have a higher rate of multisutural synostosis, where more than one of the sutures are affected, and a higher rate of increased pressure in the brain. Now we move on to surgery for craniosynostosis.
Hi there, Manish Shah again. So there are two general pools of surgery types for craniosynostosis. In both, we aim to correct the shape of the skull. One, on the left, is minimally invasive, where we have a bunch of different approaches. The primary one we use here is endoscopic, where we use a small scope, small incisions. We do the correction at an early age, and we rely heavily on post-operative molding helmet therapy, which is very important for the good outcome in this procedure, versus the traditional open vault remodeling, where we do a large incision across the top of the skull and we take off the bone and physically reshape it and reattach it to the skull and make the room at that time. No helmet is needed. This can be performed usually when the child is a little bit older. And we'll talk about both, as well as another procedure that is on the minimally invasive side called distraction. So what are the differences? Why do we choose one over the other? Well, we'll talk a little bit about that, but traditionally the open vault surgery causes more bleeding, and little babies don't have a lot of blood in them. So we tend to wait until they're older than 6 months. Often these procedures require transfusion, which is very safe. We like to avoid it when we can, but it is extremely safe, and when we need to do it, we do it. Typically, these surgeries take a little bit longer, and the child is hospitalized a little bit longer with the open surgery. The big benefit of endoscopic surgery, again, in a small child, is that there's very minimal blood loss, so it's safe to do in a small child. The surgery is shorter, the overall hospitalization is shorter, but it's all predicated on, you see that little asterisk down there, we require a post-procedure helmet therapy anywhere up to 3 months, or sometimes even longer, sometimes shorter. That is critical to making the skull reshape. So we'll go over a little cartoon diagram here of an endoscopic cranial release, and we'll show you a little video later, but we make small incisions, we put in an endoscope, this small video camera, to help us do surgery more safely through small incisions, and we take out the affected suture. So here we're just going to go through a video of endoscopic surgery. So what you're seeing is us using a cautery device to separate the scalp from the top of the bone. So this is what we actually see in surgery. Now we're about to put the endoscope into the small incision that we made in the small cut in the bone to underneath the top of the skull, the sagittal suture that's prematurely fused. And now we're going to very carefully separate the covering of the brain from the bottom of the skull using a suction device, very, very gently. And we need to do this so that we can use a heavy scissor to cut away 3 centimeters of this prematurely fused suture. Once we do that, now we're going to burn the edges of the bone, again, to reduce the amount of blood loss, because this is a small child. This child is about 2-3 months of age, and they don't have a large circulating blood volume. It's a critical part of the procedure. So now that we're done, what you see here is before surgery, you can see that sagittal suture in the middle. The shape of the head is like a boat. It's long and narrow, so boat-shaped skulls are scaphocephalic and long and narrow skulls are dolichocephalic. You might hear those two terms. Those are the two incisions. And that red rectangle in the middle is what we're aiming to do. We're aiming to take out 3 centimeters of that suture. So immediately after surgery, you see a good correction. So it's no longer long and narrow. But what's critical here, that helmeting therapy that we were talking about earlier. So what we're going to show now are some photos before and after surgery. And, we craniofacial surgeons are quite devious, and we love to show postoperative photos of the child with a lot of hair, so there's no way you can really tell the difference. But trust us, this is a lot better. So from the side, you can see the head is no longer long and narrow. And then from the top, that vertex view that Dr. Nguyen was talking about, you can see there's an excellent correction. So this is the other second most common suture that is prematurely fused, the Metopic suture. And one thing you can really note, if your surgeon is also talking to you before the CT scan about the difference between a ridge and a suture, is that the eyes are too close together in Metopic Craniosynostosis. So all these children end up needing eye exams, but before and after surgery, you can see a clear difference between the triangle-shaped head and then the corrected head. And again, here we have a post-operative case from endoscopic suturectomy. So what was important about those cases? The child wore a helmet. So here we have a nice helmet. You can decorate them any way you want, but they have to wear a molding helmet for months after surgery. So they wear them really usually 23 hours a day, get a little bit of time off. We custom make these helmets for each child to specifically change that child's skull shape the way we want it. And so here is a post-operative case. This is actually directly from the helmeting company, and you can see that we're custom fitting these helmets and custom molding them for the child. So this is a paper from the WashU group that talks about Metopic Craniosynostosis and how the outcomes are very similar. It's an excellent paper. And this is a paper that I wrote almost a decade ago now that compares endoscopic surgery for sagittal craniosynostosis versus open. And what we find in this is that the cephalic indices are equivalent between the two. And remember, that's what we're trying to correct. But that there's a very clear benefit from endoscopic surgery in terms of we didn't need to transfuse that many patients. There's a lot less blood loss. The operative time was much shorter. And, of course, the big difference is that we have to helmet the children who have the endoscopic procedure. So overall, a really excellent tool in the arsenal. So I'll turn it back over to Dr. Nguyen.
Now we'd like to discuss some very new innovations and very exciting developments that we are pioneering here at UT Health in the treatment of craniosynostosis. This child has unicoronal synostosis, as we had discussed before, but here we're going to utilize a new technique called distraction osteogenesis. You can see that the child has an asymmetric head shape and a flattening of the right side of her orbit, as well as her frontal bone. You can see from the vertex view that she has that flattened forehead. And the idea with distraction is we utilize a device similar to a ratchet that slowly over time stretches bone. So in this scenario, on a skull model, we have removed the abnormal cranial suture. We've made our cuts inside the bone to allow it to expand. And what this device does is over the course of 20 to 30 days, it ratchets slowly, stretching the bone forward. This type of technology is actually not new and has been used to lengthen limbs since the 1950s. However, it has not been used for this specific purpose up until now. The parents can actually do the turning of these ratchets at home. And you can see there's an incredible difference between pre-op and post-op. Note the difference in the nose and the midline position. Note the difference in the symmetry of the orbits. Note the difference in the symmetry of the forehead. That utilization of distraction also takes advantage of the younger patient who has softer bone, and as such is able to be done at a much younger age. The blood loss is less and the need for ICU stay is much less. I'd also like to discuss another technology known as springs. This is more commonly used in Europe and has more recently been adopted here in the United States. The idea is after removal of the abnormal suture, we place a titanium spring of various strengths depending on the age of the patient and the thickness of the bone in order to slowly push that bone apart. This essentially is a passive process. Here is one case example of a child with sagittal synostosis. Note the elongated forehead as well as boat-shaped head. A lazy S incision is made and the springs are placed and covered. This is a approximately 1 hour procedure with minimal blood loss. And as you can see over time, the spring's natural strength will continue to push the bones apart. And here that patient who had a very narrow-shaped head is now much more normally shaped. This does, however, require a second procedure, which is a small day surgery just to remove the springs.
So why is it that we don't just offer everyone endoscopic or cranial distractors? So this, we're going to talk about this entire talk, but it is very, very, very important to make the diagnosis as soon as possible and to see an experienced craniofacial team as soon as possible, because the best results that we get are when the child is young. When you wait and the child's skull gets thicker, it is much more challenging to mold the vault at that time. Sometimes the patient's craniosynostosis is just too severe, and especially when there are multiple sutures, it becomes too challenging to do this endoscopically and have the same kinds of outcomes. And then, if there's a second surgery involved, that's not going to be as minimally invasive.
However, we still have the tried and true methodology of using total cranial vault remodeling. This type of technique has been demonstrated to be very safe and very effective and has really been developed over the last 30 to 40 years. It is a larger surgery, however, you can effect a greater change. As Dr. Shah had just mentioned, particularly for the more severe shapes, this type of surgery may be more effective. One can approach the entire aspect of the cranial vault, and this is really more appropriate for the older patient. This is largely due to the physiology of that patient. The skull is now becoming harder and harder as the child becomes older in the 8 to 9 month range, and this is very safe and effective in the hands of a highly trained surgical team that does this day in and day out. There are many, many ways to do this type of procedure based on ingenuity over the years, and this is essentially all predicated on taking apart the bones, reshaping them, and putting them back into place in order to reshape the skull. These are two examples of sagittal craniosynostosis. Here's one case example of a child who had a very similar type of procedure based on removing the bone parts and repositioning them. And you can see the clear change on the table of the head shape as well as the cranial index. This is a static procedure. In other words, there is not change over time. We also want to comment upon a technique called Fronto-orbital Advancement, also known as an FOA. The idea with this type of procedure, this also falls upon the open techniques. The idea with this is that we can attend to the frontal bone as well as the orbits and reshape these aspects. This is more commonly done for Metopic synostosis as well as coronal synostosis. Here we have two examples of unicoronal synostosis. Again, note the asymmetry in the orbits. And a pre-op and post-op CT scan demonstrating the type of bony cuts and reshaping of the skull. We can see that the orbits are repositioned, as is the frontal bone. In this patient, we advanced one side 20 millimeters in order to increase the symmetry between the two sides. And this can be a very powerful technique. And you see a clear difference at the post-op visit. Also of note is the use of distraction for the back of the skull, also known as posterior cranial vault distraction. This ideology has been in place only since 2009, and the critical idea here is that this is specifically used for patients where there is not nearly enough room for the brain to grow. There is increased pressure in the brain, and our primary goal is to increase that room. Easiest way to do this is to make osteotomies or cuts in the skull and place the distractor devices to ratchet out the back portion of the skull just to create enough room. And we can see that doing this technique and attending to the back as opposed to the front, there is a significant difference and a larger difference in creating more space by using the back as opposed to the front. Also, we have seen that the use of posterior vault distraction has been able to delay the need for subsequent procedures for the front. And this may be due to the fact that there's more space for that baby to grow and that brain to develop. And subsequently, the front of the skull and the orbits also change physiologically. This is one example of a protocol for syndromic synostoses. Suffice it to say that many of these patients do require more than one operation, and our goal is to try and do the most effective operation early in order to prevent multiple secondary operations. Here is one case example of a syndromic patient who has Muenke Syndrome. You can see that this patient has bicoronal synostosis, where the head is flat and tall. In this patient, we utilize posterior cranial vault distraction in order to make room for her brain. And you can see the devices as they exit. They look like antennas. These are subsequently removed at a secondary operation approximately 3 to 6 months afterwards. So to conclude, evaluation of abnormal head shapes should really be done by a trained craniofacial or neurosurgeon to assess for signs of craniosynostosis as well as any signs of increased pressure within that brain. It is critically important to determine the difference between craniosynostosis versus the more common deformational plagiocephaly.
So we hope you've been informed by this talk, and I think a couple of take-home messages. Early intervention is critical. So the sooner we get the diagnosis, the more options we have. And we talked about endoscopic, minimally invasive surgery can reduce that need for a bigger surgery later, but it can only be done in a younger patient, or distractors that we can place in a younger patient. So early intervention, early diagnosis, that's what's critical here. So thank you very much. We love our patients. And this is a picture of us with one of our wonderful babies. So thank you so much for listening.
You can reach us at the Texas Cleft and Craniofacial Clinic here in Houston, Texas. The address is below, as the phone number is as well. Please give us a call should you have any questions. Thanks very much.